Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Zahid Mumtaz, resident cardiologist, moderator for this session. We have actually switched the session of hypertension before cardiac imaging. So cardiac imaging will be first and then hypertension. So this session is of cardiac imaging. I would like to invite our panel of experts, Dr. Shehbaz Qureshi, Dr. Tariq Ashraf, Brigadier Dr. Zahoor Aslam Khatak, Dr. Nusrat Ara Majid, and Dr. Ghulam Rasool Mekan, and Dr. Kamar Bhatti to come and sit and join us. For the first talk, I would like to invite Dr. Abidullah, consultant cardiologist, PIC, for his talk on CT angiography in coronary artery disease and structural interventions. Thank you, sir.
Bismillahirrahmanirrahim. I think we have much lesser audience to start with, but I can promise you this is going to be as interesting, if not more, than what we have seen so far. So I'm going to talk about CT angiography in coronary and structural heart interventions. And I hope by the end of the session or by the end of the talk, I might have convinced you that every cardiologist should know the CT, be they are invasive or non-invasive cardiologists. So the outline of my presentation will be, I'll briefly talk about the CT coronary angiography and its place in the current diagnostic pathway. I'll briefly touch upon some clinical trials and the evidence supporting its use. I will talk about some exciting new uses of the CT, but mostly I'll be showing some interesting cases that you all might find helpful. We all know that it's a time of rapid and very exciting changes in the field of cardiac imaging, be they invasive or non-invasive. The CTCA has established itself as one of the most advanced non-invasive tests of the coronary anatomy, and it can be used for detection of the coronary plaque, but in particular the exclusion of obstructive coronary artery disease. And in good hands, with good techniques, you can get as good pictures as with invasive coronary angiography, and that should guide your management. The clinical effectiveness has been proven beyond doubt by many trials, but I'll just mention a few. The SCARD Heart study was one of the major studies carried out in the UK, enrolling more than 5,000 patients. The promise is basically a comparison between the CT coronary angiography and a myocardial perfusion scan, and then we have the Danish registry, and it's on the basis of this growing body of evidence that the ESC and the AHA both have given 1A level of evidence for CTCA to be performed in the stable coronary artery disease. And with that, I'll come to my first case, why CTCA should be a true gatekeeper for cath lab procedures. A 20-year-old gentleman, he presented to us with chest pain. The ECG had some changes, and his troponin was mildly elevated at around 15. Echocardiography was borderline for some hypokinesia of the interior wall. These were the initial days of our institution, but we had the benefit of having the CT. So there was some myocardial bridging in the LAD, but otherwise the LAD was clear. The rest of his coronary artery was clear as well. As I said, those were the initial days, so the primary consultant was not very comfortable with a 20-year-old gentleman just having a CT. He went on to do an invasive coronary angiography on this patient, and unsurprisingly, totally unobstructed coronary arteries. So that's why when I call it a true gatekeeper for a cath lab, it should be a true gatekeeper for a cath lab. Second case, a 57-year-old lady, atypical chest pain, normal ECG and normal echo. Because of the atypicality of the pain, she went on to have a CT scan. And the right coronary artery has a tight stenosis, very focal tight stenosis. This patient appropriately goes on to have an angiogram. Which confirm the stenosis exactly at the position where we can see it with the CT. It makes it easier for the operator to take this patient and perform an angioplasty very appropriately. Patient with previous CABG, I think it will become increasingly difficult to take patients for invasive coronary angiography before doing a CT. It shows you the grafts, their numbers and their location, and any potential targets for intervention. I will briefly mention the bypass CTCA trial, which was presented in TCT about 2 years ago. 688 patients were randomized 1-to-1 to CT coronary angiography plus angio and then angio. And the results were astonishing, but unsurprising. The primary endpoints, procedure time reduced from 39 minutes to 17 minutes. So 66% reduction in the procedure time, 92% reduction in the kidney injury, and 44% increase in the patient satisfaction. And if you look at the secondary endpoints, they were equally as impressive as with the primary endpoints. And when I say it's unsurprising, anyone getting good images like these for a grafts, why wouldn't they do a CT before taking a patient for the invasive coronary angiography? CTCA can also help any interventional cardiologist in planning their intervention. In catheter selection, they can anticipate case complexity, the lesion location and length, and the use of any adjunct therapy or a plaque modification when they are doing the procedure. And that brings me to my third case. A 54-year-old male, smoker, hypertensive, chest pain. He had positive ETT. We took him to the cath lab. Looks like a big right coronary artery bag filling from the left system. And we could see that there was a tight lesion in the RCA. Now, luckily, this patient had a CT before, and the lesion did not appear to have any calcium. So all we needed was a NC balloon and some cutting balloons, and we knew that we didn't need any rotational atherectomy for this patient. And it's not only the intervention, for a prevention as well. Calcium score is a powerful tool which is available to us now. A calcium score of 0, Framingham risk score will be very low, and their 10-year event rate is less than 2%. As the calcium score increases, their risk increases, and their event rate increases. So any patient having increasing calcium score just on the non-contrast CT, we can better plan their prevention, and we can better prevent them from having events down the line. And I think we are lucky, because with that level of evidence, the PARC-SEAT study, I don't know how many of the audience is aware of that. It's a study which recently started in the last 6 months or 8 months. CTCA is done at baseline in 5 years. 2,000 patients across Pakistan are recruited. We have just contributed 200 patients from PIC Peshawar to that. Hopefully, it will help determine the risk factors for coronary artery disease in our population, and hopefully it will aid to the biobank that we do have in this country. It's a bit too quick. So a few novel uses for the CT. I think the most exciting development is the CT-derived FFR. So with the invasive coronary angiography, I think the landscape changed when we had the pressure wire studies, and I think the same will be, or the same is with the CT FFR, and I'll show a few cases of the CT FFR as well. 73-year-old gentleman, exertional chest pain, hypertension, and dyslipidemia. On a CT scan, he had plaques in all the 3 coronary arteries. So it appears he has a 3-vessel disease. We had the luxury of having a CT FFR, not here, it was in the UK, but it shows that there's lesion-specific ischemia in the right coronary artery, but no lesion-specific area in the left system. So this patient goes on to have an invasive coronary angiography. He has disease in the LAD and in the circumflex, but significant diseases in the RCA. So basically, this patient only needed intervention to the right coronary artery. And we actually published the results of our data. It significantly reduces the downstream investigations after a CT and increases the efficiency of whatever is available. Coronary anomalies, CT is the most important investigations for coronary anomalies. 48-year-old female, she has a CT, and we can see that the left coronary artery is arising from the right coronary cusp. It will be an unforgivable act if we don't get these patients for a CT. So this patient goes for a CT. Because we need to know, do we need to do anything for this anomalous coronary artery? And if I can point here, this is the aorta, this is the pulmonary artery, and we can see the left coronary artery is arising from the right cusp. It's intra-arterial, and this is what used to be called as the malignant course. This patient was referred to the surgeons for re-implanting of that, and we can see that in the 3D as well. I'll skip my case 6. I'll go to case 7, which again is an anomaly. So this patient first had a CT. Again, we can see in a minute it will come, right coronary artery, intra-arterial course. But again, we had the benefit of the CT FFR, and we proved that this intra-arterial course was significant, and this patient needed surgery to re-implant this right coronary artery. I'll briefly touch upon the role of the CT in structural cardiac interventions. TAVI, everyone would agree that no one should be doing TAVI without knowing their CT. The TAVI operators cannot depend on the radiologist to do the CT for them. It shows them the access site, shows them coronary artery and height, annular dimensions, and the angle of the valve deployment. So this is basically the access site that we measure for the TAVI. Shunt and left atrial appendage closures cannot be done without the CT analysis. And the same is for the left atrial appendage closure. So I think in summary, it's an essential skill for all cardiologists. It has new and expanding usages. Every interventional cardiologist should be trained in the CTCA, and I believe it should be widely available with necessary infrastructure and expertise. We, the cardiologists, by performing the coronary angiography, are the gatekeeper for coronary intervention and by extension for cardiac surgery. But I strongly believe that we are moving into an era when the CT is going to be a gatekeeper for all these procedures. And I'll leave you with one image. Why wouldn't you do a CT if you can get beautiful images like this? Thank you so much. Any questions?
What is your experience of surgical intervention in patients with malignant course of right coronary artery?
It
And
varies.
even left coronary artery.
Yes, it varies, sir. The majority I have seen have been the right coronary artery reimplantation. Some of them have been good, and I think the results vary from center to center. Some of them, if the ischemia hasn't been proven significantly, then their grafts usually don't grow. And I think there's a drawback of that. We had one case in the last 1 year who had a rema to the right coronary artery, and the rema did not grow. So there's something for a surgeon to ponder.
So here's one more question. Excellent presentation, very informative. I just want to ask, we used to go for the screening process of our young patients to go for the CT angiogram. Primarily, do you think if his or her calcium score is below 100, it's around 50, so we need to complete the complete angiogram ahead, seeing the calcium score, we are going it for the primary screening purpose. So do you think we should go ahead with this 50 coronary artery calcium score?
So I'm a strong believer in doing a calcium score in each and every patient. A high calcium score should stop you from doing a CT angiogram, but a low calcium score shouldn't stop you, because on the CT calcium score, you wouldn't be able to see the soft leg. So you will miss the soft leg if you don't do the CT angiogram.
Well, just let me add something to it.
Yes.
You said a low calcium score, you have to go for angiography.
Yes,
Even if it is a zero calcium score, you should do an angiogram.
that's right.
Because I have seen many cases where the calcium score was zero,
Absolutely.
and the patient is having left main
Yes.
significant disease.
Yes, yes. That's the point I was making as well. So the soft plaque wouldn't appear on just the CT calcium score.
Dr. Abid, basically, you see, when we are doing CT angio, the calcium score should not bar us from doing a CT angio at any level. because now when you're talking about the interventional cardiologist taking the help of CT angio, you can actually see that the calcium around the coronaries is just in a way that you would be seeing it on the IVUS. So I think that at any level of calcium score, where even if it is 1500, 2000, I have done it there and I've found it to be very useful in these patients. So I don't think that it should only be restricted to a low calcium score. It can be done at any level of calcium. It's not a contraindication. That is important.
Yeah. Yes.
And the
I agree,
other,
sir. Yeah.
yes, please.
Yeah. The only exception I'll make if there is very dense calcification, circumferential calcification, because it gives blooming artifacts, and then you have to balance the risk of giving contrast and the risk of giving radiations without getting any diagnostic information. So if it's a very dense calcium, it usually doesn't give you much information. But I agree that it might give you some.
You see, basically what you can see it in the multiplanar, you can see it on the cross section at all the levels, and you will be able to find out what the lumen size is there and how much calcium is around circular at that area.
Yes.
The other very important point in patients who undergo CT angio is the management of the heart rate. And normally, when we are talking about the beta blockers, what I find is that ivabradine in a dose of 7.5 milligram, 2 tablets, 3 days before you do the angio, you start with that, the heart rate rarely jumps. And I think the ivabradine is a much better way to control the heart rate than the beta blockers. But even if you are using the beta blockers, you should not go to a small dose. You can go to as high as 30 milligram when you are doing a CT angio, and that is the only way you will control the heart rate. With an uncontrolled heart rate, don't do a CT angio. That is important.
Again a very important point. So firstly, you wouldn't get any good images. Secondly, the higher the heart rate, the higher is the radiation. Okay. So when I started learning my CT, my consultant was a German. And he said, Abid, the best image I would get if I can give the cardiac arrest to a patient. So the heart is stopped and I can take pictures and then we restart. Obviously, that's not possible. But the slower the heart rate, the better it is.
And I think I do believe we are underusing CT in our procedures. How about those patients where we do echo? And in valvular cases where we are unable to make our decisions, does CT help in those cases in making our decision for surgery?
Yes.
At times when we are confused with our echo or other non-invasive modalities.
I'm a great enthusiast of CT, but I think CT so far has only been an anatomical test. So anything which to deal with the physiology, CT is very weak in them. We are getting the 3D or 4D flow models now, but still their resolution is not as good enough. So for the valves, it's always going to be the echo or the MR. For a TAVI planning, it's going to be the CT. For a mitral clip, it's 50-50, but still for them, it's going to be the echo at the moment. So CT for the valvular assessment, I don't think it's there yet.
Using these CT, where do you feel that CT is not going to decide, and how do you compare results of CT with cardiac MR, and what are the conditions where we think that now CT is not going to help and MR would be more of a help?
So CT is going to be an anatomical test. It's only going to show you the anatomy. If you are interested more in the physiology, in the valvular lesions, in the perfusion, it's going to be MR. So CT is anatomy, MR is physiology.
Abid, as regards the calcium score, I think it's important that one should do it because you can actually risk stratify and think of those patients who will be put on statins and on aspirin. And I think calcium score will give you an idea in these patients. And this should be a screening tool now for coronary artery disease because calcium means atherosclerosis. The other important aspect which is now being investigated with the CT is the epicardial adipose tissue thickness. And that you should do when you're doing an axial image, you calculate the adipose tissue there, the thickness, and if it is more than 7 millimeters, this is a high-risk patient for atherosclerosis because adiposity is a pro-inflammatory state.
Okay, thank you.
Thank you, sir, for your presentation. For our next speaker, I would like to invite Dr. Inamullah Numan, Consultant Nuclear Medicine, Head of Department Nuclear Cardiology, FIC, for his talk on myocardial ischemia, MFR with MPI.
Thank you very much for the invitation. Greetings from Nuclear Cardiology. It's always a pleasure and privilege to attend this meeting. So I'll be discussing briefly and very briefly the role of myocardial flow reserve as part of traditional myocardial perfusion imaging for the assessment of coronary artery disease and ischemia. I don't have any disclosures. As we all know that SPECT MPI is a time-tested and diagnostic and prognostic modality. However, its performance is challenged and is limited by a fundamental drawback, and that is that it assesses the relative perfusion of LV myocardium in relation to the area with highest radiotracer uptake. So in cases where there is a global reduction in the myocardial perfusion, like in case of multivessel disease, triple vessel disease, or balanced ischemia, the extent and severity of coronary artery disease detected is underdetected and underestimated. So this fundamental challenge has been amicably addressed by one of the most exciting innovation in the nuclear cardiology, which is the measurement of myocardial flow reserve as part of traditional perfusion imaging. Incorporating myocardial blood flow into the traditional SPECT imaging improves the diagnosis of epicardial disease, improves the assessment and extent of severity of epicardial disease, improves risk stratification, as well as the patient selection for coronary intervention versus medical therapy. And importantly, as in the morning session, we were talking about the microvascular disease. This is the right test, as Dr. Dima also suggested, that MFR is the right test for the diagnosis of microvascular disease. Additionally, it assesses the adequacy of the pharmacological stress and identifies the non-responders, especially in case of pharmacological stress. So this is the standardized protocol, which we also follow at our center at AFIC. We acquire the studies using state-of-the-art CZT gamma camera, and we use technetium maybe with adenosine-induced stress. However, PET remains the gold standard for measurement of MFR. This does not involve any additional time or radiation dose, and it assesses the entire coronary delivery system. And it assesses the entire coronary delivery system, including epicardial vessels as well as the microvasculature. So this is our center, and this is the pioneer and sole facility in the country for the dynamic SPECT MPI studies with MFR measurement at AFIC. So a typical value of greater than 2 is considered normal for the global MBFR and is associated with the low risk for any severe coronary artery related event or MACE. So I'll go quickly for the clinical cases. A 65 years of age hypertensive lady presented with exertional chest pain. 2D echo was fairly normal, and CT angiography showed moderate disease in mid-LAD and critical osteal disease in non-dominant SIR. So the cardiologist was interested in the hemodynamic significance or the prognostic significance of these flow-limiting lesions, and we did a SPECT MPI, and we found that there was no adenosine-induced perfusion abnormality. LVEF was preserved and the ischemic burden was nil. However, still we are not comfortable with this normal myocardial perfusion scan because we do not have any idea about the adequacy of the pharmacological stress. We do not know that we cannot confirm with this scan that patient didn't take any caffeine. We are not sure about the coronary microvascular disease and we are not sure about the multivessel disease. So luckily we did a MFR scan, dynamic scan for this patient, and we found that there was a normal rise in the stress flows during the peak stress. So the normal MBFR confirms the steady normalcy beyond normal perfusion and indicates lower risk for CAD beyond normal perfusion. So international data shows that a normal global CFR even with presence of slightly or moderate abnormalities, have a high negative predictive value of 0.97 for any high-risk disease on angiography. So there is another case that we had recently in the last week. So the perfusion of this patient was quite normal. However, there was no rise in the stress flows. So we asked the patient about the caffeine intake. The patient was adamant that there wasn't any caffeine intake. So we I told the patient that we'll go for an angiography, but then he's narrated that he took Naswar. So in this way, this is the modality from which we can identify the non-responders or the failed vasodilator response. Later we did stress scan again yesterday, and we found that there was a normal rise in the stress flows. That was the important discussion in the morning session about the microvascular dysfunction. So MFR, we are fortunate that MFR is now available to address and diagnose a large population proportion that was going undetected previously, and we have this technique available in Pakistan as well. So I'll skip this case as I'm running short of time. So these are the few of the comparisons that international investigators have done and have compared the CGT SPECT as well as the PET MFR measurements and have found a good correlation with R value of greater than 0.8. These are few of the factors affecting MBF measurement. So the take-home message is that MFR as part of routine and conventional MPI comprehensively evaluate the chest pain, unclear cause of TID, abnormal ECG with normal perfusion, and it improves the extent and severity of CAD, improves the detection of balance ischemia, lack of vasodilator response, suspected microvascular disease. Greater the MBFR correlates well with the excellent prognosis. Lower the MBFR in the setting of no known CAD requires further testing. And lower the MBFR, greater the likelihood of multivessel disease, and worse is the prognosis, and greater the likelihood from benefit from revascularization. So a last question that everybody asked, that is dynamic SPECT MPI is ready for a prime time? I think probably no, and it would never be as good as PET imaging. So I just added this slide because there was a discussion on it in the morning session. So these are different scenarios and which are associated with MBFR, and it helps in the diagnosis of INOCA, ANOCA, MENOCA, as well as CMD with ischemia or diagnostic criteria for the CMD. So this is very useful tool, and I think in 2024, where we are talking about the patient-first approach, right test for the right patient, I think every nuclear cardiology department in the country should have MFR facility. And although the gold standard is PET, but CGT SPECT has also good adds value to traditional MPI. Thank you. Any question, please? Thank you very much.
Hello, just excuse me. in your patient, in the scans that you showed, there was a lot of tail there. And that can actually give you, the interpretation can become faulty there. What measures can you take to get rid of that tail?
Tail means the extracardiac activity.
The extra cardiac.
Yeah, that is the biggest challenge that we are having with this CGT and in the SPECT imaging, because we are using MIBI, which has the challenge of extracardiac activity. The international centers are using tetrophosphine, but that's costly. That's why we are not using it. But PET has very effectively addressed these challenges. But still, we find at least 15 to 20 patients in which we are seriously challenged by this extracardiac or visceral activities, and we do not report the MFR if there is some challenge. And we go for even for the repeat study, and or we mention that the study cannot be interpreted due to extracardiac activity.
When you're taking the resting image, what is the advice that you give to your patients? Because that is the time when you need to get that radioisotope away from the stomach.
Yeah, we actually, as I showed the protocol, there was, we advise the patient, we take first dynamic imaging, we wait for 25 minutes. During that, patient takes some meal so that the extra cardiac activity from the stomach or from the gallbladder, it goes out, and then we go for the static imaging, and along with the static imaging, we do the dynamic stress imaging. And after then, again, we wait for the 25 minutes, and patient takes some meal, and then we go for the traditional static images.
One of your slides, you were showing a balanced ischemia.
Yes.
When you have a balanced ischemia, what other parameter that can you see to say that this is basically a balanced ischemia and
Yes.
not a negative one?
Yeah, traditionally we were depending upon on the ejection fraction, falling a drop in the ejection fraction during the stress phase, as well as the transient ischemic dilatation. But the recent data shows that transient ischemic dilatation, even with pharmacological stress, has a higher limit, around 1.35, which is with the physiological stress, it is around 1.2 to 1.23. But we correlate with the angiographic report, as well as the drop in the ejection fraction, as well as the TID. So all these factors then
So I think transient ischemic dilatation is very important, and one should look at that.
Exactly.
And in fact, it should be reported.
Yeah, we do report in every patient. Thank you.
Thank you, sir. For our next presentation, I would invite Dr. Jamal Khan, who is joining us via Zoom. He is consultant cardiologist and lead for cardiac imaging and cardiac oncology. His topic is multimodality imaging in mitral regurgitation.
Hi, Assalamu alaikum, and thank you to you all for the kind invite. Can I just check that you can hear me at the moment? Could I have some confirmation that you can hear me?
Yes, sir, we can hear you.
That's great. Thank you very much. I'll just share my slide set. May I confirm that you can see a PowerPoint?
Yes, sir, your screen is now sharing.
Okay, excellent. So, yes, Assalamu alaikum and good afternoon, everyone. Thank you for the kind invite to present at this excellent Congress, and it's a real honor to be invited. I have no conflicts of interest in my talk. My talk will be looking at multimodality imaging of mitral regurgitation to really give you all an insight into what we have available at our fingertips in 2024, and hopefully give you a little bit of insight into some modalities that you may not be aware of in the use of mitral regurgitation, and also help broaden the indications and uses for the modalities that you practice every day. Because mitral regurgitation is becoming a more complex lesion with more complex pathology and a greater range of more complex techniques to manage. So the complexity of imaging should accompany that, and we have a lot more at our disposal.
We cannot clearly hear what you are saying.
Is that clearer now?
Hardly better.
Is that clear? Good. Okay, well, I'll start again. So, yes, I'll be talking to you about the multimodality imaging of mitral regurgitation, really to give you an insight into what you have at your disposal in 2024, which will probably be a lot more than one may envisage. And it's not all about transthoracic and transesophageal echocardiography. We have a lot more at our disposal than we think. And I think this is extremely important. Mitral regurgitation is the most complex lesion in the heart, and its treatments are becoming more advanced. And this really requires us to have a multimodality approach to managing this and investigating this. And I'll give you an insight in today's lecture into what you have at your disposal and what you may already have, but may not be using for mitral regurgitation. So it will be a quick tour. It's about 15 minutes, but I'm going to try to cover quite a lot of material. So I'll be happy to take any questions at the end. I have no conflicts of interest. So the mitral valve is the most complex structure in the heart. It's not just a valve. We have a lot more to the mitral valve than the valve itself. It consists of 5 components. We have the leaflets, the annulus, the chordae, the papillary muscles, and importantly, the LV. And if any of these aspects becomes abnormal, then the valve will become regurgitant. So I don't like to call it the mitral valve. I call it the mitral valve complex because it is really much more than just a valve. When we're assessing the valve, we really need to talk about the anatomy and structure. We should be talking about the severity of mitral regurgitation. There's various guidelines that you can use. This is the British Society of Echocardiography guidelines. The ASE and EAE are very similar. So very detailed quantitative analysis is needed. Every case of mitral regurgitation, we should be talking about the mechanism, whether it's primary or secondary, and then which Carpentier classification. And this is critically important because this directly affects the management. And then really, we should also be talking about the left ventricle in every case, because the left ventricle is not only affected by mitral regurg, but also can be the cause of mitral regurg, especially with ischemic MR. And then we have to remember, and I think my previous speaker colleague, I thought it was really important what you said, that everything we do is about the patient. There's a patient at the end of this. So all of our assessments are in order to manage the patient. So the detailed, comprehensive assessment of mitral regurgitation is because it makes a difference to the patient. When we have the anatomy, the mechanism, the severity, and the left ventricle confirmed, then we know which type of mitral regurg it is, and we make the right management decisions, whether it's primary or secondary mitral regurg, and whether it's medical, transcatheter, or surgical intervention. I won't go through these algorithms because these will be available to yourselves from different societies. So really, the traditional management of an assessment really of mitral regurgitation has been based on transthoracic echo and TOE, which are extremely powerful modalities. I am a multimodality imager. I practice TTE, stress echo, 3D echo, TOE, CT, and MRI, and I value all of the modalities equally. They all have pros and cons, but traditionally, mitral regurgitation has been assessed with transthoracic echo and TOE. And they are very, very powerful. They are the first line, and they will always be first line and give us a whole wealth of information. But there are, in the modern era, limitations of these techniques and some deficiencies of these techniques where we do need to have other options. And the options I will go through are multimodality aspects, which I assure you, you will all have at your disposal already. And I'm really hopeful that after this talk, these are aspects that you can start practicing and using, because we will be surprised you have all the equipment at your disposal already. It's just about making more lateral and newer uses of what you have in front of you. So the issues with transthoracic and TOE, although they're very strong, they can lead to, we can have issues where we have blind spots, where we don't see certain aspects. Can you see my mouse pointer moving? May I check? Can you see a mouse pointer? Pointer options. I'll try a laser pointer here. So we can have blind spots where there are certain things that we don't see, or we may have what we call almost like a snowstorm where we can't see things clearly. So there will be occasions where transthoracic and even TOE will not provide the information that we need, or provide a substandard assessment of the valve. And they can affect all 5 of the components that we talked about earlier. They can affect assessment of the anatomy and structure. of the severity of MR, the mechanism of MR, the left ventricle, and also then ultimately effect management. And as you can see here, these are the deficiencies for in each of these areas of transthoracic and transesophageal echo, potential deficiencies, really where you may not be able to see all of the views. The views may be dependent on the echo windows, the size and shape of the patient. They may be dependent on the cut. There may be artifacts. For severity, especially, the jets may be eccentric, which means it's harder to quantify them, and subjective assessment of mitral regurgitation must be avoided in every example. We cannot rely on subjectivity. It's simply not good enough. We need to make sure there is comprehensive quantitative data, and we must have an EROA in every case. And with an eccentric jet, you may struggle due to eccentricity. Again, with the mechanism, the views may not allow assessment of mechanism, and this will adversely affect care. The left ventricle, we need an accurate assessment. We need volumes, biplane volumes minimum, and function in every patient, and 3D ideally, because these can drive management either as the cause or the consequence of MR. So we need some way of managing and getting around all of these deficiencies. So really, this is what I would like to say today, and this is what I will talk for the next 10 or so minutes. TT and TAE are fantastic modalities. They've been around for 30, 40 years, and they are always our first line. And I'm a proponent like yourselves of these techniques, but they are the tip of the iceberg. There is much more available in 2024 and much more that we need to use. If we are reliant on simply TT and TOE, I don't think we will assess mitral regurg in the detail that we need to in the modern era, especially with newer techniques coming in to manage them. So these are the areas I'll talk about today. There'll be 4 areas that I will talk about, and I'll go through them quickly just to give you an insight. And these may be techniques that you're using already, or they may be new to you. The first one is 3D echo. So standard echo is 2D echo. All you're doing essentially, if this is a box that we have here of some sweets, a 2D echo will simply take a picture of the front of the box, and a 3D echo will take a picture of the whole box. And this is much more powerful. Inside this box here, let's imagine this is the heart, and inside this box, in the middle of the box, is a structure that you need to look at. If you take a 2D picture of the front, you cannot see what's in there. With a 3D acquisition, you acquire the whole volume, and it's like a CT. You own that full volume. That volume is yours once you've acquired it, and you can cut it, crop it, spin it around, look at it from any direction, and look at any structure within it. So everything within that volume is acquired, and you can look at any structure from any angle, and we will never have that problem of eccentric jets or structures that are not seen. So when we acquire a 3D image, we tell the machine how much of the front of the box we want to look at and how much of the depth, and then it acquires that whole volume as one data set. And you may be using this at the moment. This has been around for quite a long time. This gives us anatomical and functional information. And really the key thing is in that single, this is a 3D volume set. This is what is produced. It takes 15 seconds to produce this, and this is a wedge of data. This is that whole box of sweets. You own everything inside that. So you can post-process this. You can look at the visual image, which is like a video camera, which is really nice, visual assessment, but the power is really you can post-process this into what we call multiplanar reconstructions, which the CT and MRI faculty may be more familiar with. And you can look at any structure from any angle. So here we have a P2 flail. We may not see that on 2D echo, but we use our multiplanar reconstructions to manipulate the image, look at the image from any angle, any aspect, and any perspective, and we will always get the right anatomy. And this is extremely powerful. I do this in every single TOE that I do, and it's really changing the game when it comes to echocardiography. So this is an example of a case of how we will do MR, a 3D echo in mitral regurg. This is a TOE, a chap under my care who's got, they've said he is short of breath, has mitral regurgitation, but the valve cannot be seen clearly due to limited echo windows, and the degree of mitral regurgitation cannot be quantified accurately because the jet is extremely accurate. So we have an unhelpful situation where we have a valve where we cannot characterize it. We don't know if it's moderate or severe. We do not know if the LV is dilated or not. And this is going to harm the patient because his management depends absolutely on these aspects. We must be certain on how severe the MR is, what the mechanism is, and what the left ventricle is like, because that will be our indication for surgery if needed. So with literally 3D images alone, 3 acquisitions from 3D, 3 images, which take 30 seconds each to acquire. Number one, we do an acquisition of the valve structure. As we saw earlier, we fully segment the valve out. We get beautiful 3D volume rendered imaging with real-time imaging, almost like a video camera of the heart. And we can absolutely 3D map out the valve, give exact information on which scallops are affected, annulus, size of leaflets, and this is the information the surgeon needs. So one image provides all of this data. Second image is we do a 3D color image. On color, we acquire a 3D volume set. And this is an eccentric jet. You will struggle to get an MRVTI and EROA, but now you own that jet. You have an eccentric jet, which we then spin around 3D, so the jet is looking right in front of us. So we now have our 3D vena contractor, and we absolutely get the EROA with complete confirmation. Finally, the LV. Simpsons will make assumptions. 3D echo, we acquire the same image of the LV, and we fully segment out the left ventricle in three-dimensional.
Excuse me, sir. Sorry to interrupt.
Yes.
Sir, we are short of time. Can you please find it?
I will move on quickly. I've got 5 minutes to go and I'll be very quick. So this is the case that you get now. You have a beautiful assessment of the mitral valve where you've got flail P2, severe MR. You have a dilated and impaired LV. So this patient now goes for surgery. You will not get this from 2D echo. We can use this 3D echo is absolutely crucial for tear assessment, which you may be doing in Pakistan, to get assessment of the suitability of the valve for tear is critically important. And also can be used intraoperatively to guide the procedure beautifully. And the other aspect is 3D echo is not the domain of TOE. It is equally applicable for transthoracic echo. This is the transthoracic 3D, beautiful tear assessment for a patient who could not tolerate a TOE due to varices. So next aspect is exercise stress echo. I'll be very quick on these next ones as fast as possible, but they are crucial for you to hear about. Exercise bike stress echo, non-ischemic stress echo for valve disease. This is a game changer. This is done where there's a mismatch between symptoms and severity. You have a non-severely regurgitant valve, a moderately regurgitant valve, but severe symptoms. Breathless patient, no other cause. But you cannot operate because you don't meet severe criteria. The patient misses out on surgery. Or you have a patient with severe regurgitation, but no symptoms. So we have a mismatch. The patient with breathlessness and moderate valve disease, is it really moderate? The patient who is severely regurgitant but has no symptoms, are they really asymptomatic? And these will be patients who will miss out on surgery because they will have resting moderate disease and never meet criteria for surgery. So we do a bike protocol, WHO protocol, 25 watts increase every 2 minutes, and we exercise them to volition till they hit the wall. And this is the key. So if you have patients with breathlessness, with non-severe valve regurgitation, and you've looked for every other cause, this patient will be stuck in a cycle where they cannot move further. This patient needs an exercise stress echo. Is this moderate at rest but severe on exercise? So we exercise the patient, and if they have a PAP increase to more than 60, if the LV does not increase by more than 5% ejection fraction, that means you have pulmonary hypertension and you have a loss of contractile reserve, even if they're asymptomatic or they have normal LV size and volumes and function. If you put them on the bike and they get a PAP of 60 or more and the EF does not go up by more than 5%, this patient needs surgery. This is the cause of this moderate MR at rest. It's actually severe and they have class 1 indications. So last as two sort of areas. So this is just an example of an exercise stress echo case and the value. So this is a lady with a severe ischemic MR, breathless, and she's got LAD ischemia. What's the problem? Is the breathlessness due to LAD ischemia or ischemic MR? So we put her on the bike. She does the exercise stress test. She gets breathless after 4 minutes, but actually she develops a new wall motion abnormality in the LAD territory, and her PAP stays below 60. There's no increase in MR severity. This breathlessness is not ischemic MR. This is the LAD. She was stented and better. So this is not hemodynamically significant MR. So the MR is not the main cause. This is the opposite case. A young man with a prolapse who had his valve repaired in Portugal 2 years ago. He is now feeling that he has no symptoms but has torrential MR because he has a fully fixed posterior leaflet. The LV is dilating. He does not want surgery. He says, I don't want anything. I have no symptoms. I'm not confident in leaving a young man with severe MR like this, whose LV is dilated. I put him on the bike. He has the opposite. He manages 14 minutes, but that's only 79% of age and sex criteria. His PAP goes up to more than 60, and he has no contractile reserve. He actually needs surgery, so he agrees. The last two sections, very, very quickly, cardiac CT. You may think, why am I talking about cardiac CT for MR? This is absolutely crucial in the modern era, especially with transcatheter therapies. So the benefit of CT and MR is you have the best spatial resolution, 0.5 millimeter isotropic voxels, unparalleled spatial resolution, very, very crystal clear images, so you can get the most precise anatomical measurements of annuli, of LV outflow tract obstruction for TMVRs, for mitral valve orifices. If you have a stenosed valve, on the echo, you'll see something bright. Reverberation. What is it? Is it pannus? Is it thrombus? Is it calcium? You do a CT, you will absolutely conclusively show what it is because they all look different. They have different attenuation, so you can tissue characterize. The new scanners are fast, one single heartbeat, the whole scan is done, and you can get volumetric data and moving data. So this is a case of a CT that I've done on a patient with mitral regurg. This is a dilated cardiomyopathy. This is just showing you the spatial resolution that we have moving images. You have the same information that you can get on an echo now, whilst getting a CT and all the coronary artery information. And you can beautifully assess the volumes, and you can assess the mass. At the top here, I'm walking down the valve, AL commissure down to PM commissure, and then I can segment any part of the valve out. And we can get full volumetric data now as well, like we would on a cardiac MRI. So in the same scan, you get coronaries, LV mass size, volume, function, and very, very detailed assessment of the valve structure. These are just some quick fire cases for 30 seconds. These are real life cases that I've done. These are just standard cases from my list. This is a stenosed mitral bioprosthetic valve. What is the cause? Is it thrombus? Is it pannus? Is it calcium? If it's thrombus, you anticoagulate. If it's pannus or calcium, you need a redo. This is a beautiful case showing pannus. Pannus starts below the ring and grows inwards, 100 to 150 Hounsfield units. This is not thrombus, redo valve. This is a patient whose gradients are going up. Why is the gradients going up? Has he got severe stenosis? Poor echo windows. We put the patient in the MR CT scanner, you see beautiful normal occluding movement. So if this valve is opening and closing normally, the reason for the increased velocities are because his LV is improved. This is a case of a TMVR that I did the workup for in a patient who's had a previous TAVI and has severe MAC. This is a valve in MAC TMVR. The question is, what is that LVOT going to be like when we open the valve? We flip the doors open on the valve. If it's less than 1.7 centimeters squared, we cannot do it. It's fine. This is a tier assessment that was done with CT. Man can't tolerate CT. Yeah, last two slides are MRI. So MRI.
Please try to wind up a lot of time.
Okay, so MRI. So here you go. You will get fantastic MRI valve assessment. You can accurately quantify a valve regurg, function, anatomy, structure in one scan. Two very quick, 30 seconds each. This is a young boy. He has pectus excavatum. Cannot get any echo windows. He looks like he has mitral valve prolapse on echo, but you cannot assess it. TOE, he cannot tolerate. We do a CMR. We absolutely crystally see the pectus. We see the valve segmented in full, all the scallops, all the commissures. We quantify the MR. We see mitral annular disjunction. In the same scan, we tissue characterize to look for high-risk features for arrhythmias in MAD. Ischemic MR, you can quantify the MR and also show scar and viability. And the final scan and the final page is a summary, really, that mitral regurg is more complex. It's come on a lot in the last few years. You have all of these modalities at your disposal in your hospital. You'll all have 3D echo, all have CT and MRI, and all have bikes. And these are things that you can be practicing yourself every day, and they absolutely make a difference to patient care. Without these assessments, I don't think we can accurately assess all mitral regurg cases. Thank you for your time.
So our next speaker will also join us via Zoom. So she is Dr. Aisha Khan Khel. She will give a talk on the topic why CMR.
Thank you. I'm just trying to share my screen.
Yes, now we can see.
Okay, can you see that as a full slideshow, not as a proper presentation, yeah?
Yeah, we can see the slideshow.
Okay, perfect. So thank you. So thank you, Assalamu alaikum. Thank you for inviting me to talk today on why CMR. Okay, so the aims of my talk are to go through the indications of why we use cardiac MRI, go through some cases to illustrate the practice of cardiac MR in my institution, and point you to some useful resources for cardiac MR training. So what's so special about CMR? We have echocardiography. What does MRI add? Well, it's the gold standard for ventricular size, volume, and function. We can get reproducible serial measurements, and this is useful when we're performing congenital scans or when we're looking at dilated aortas, for example, or looking at hypertrophic cardiomyopathy and wall thickness and comparing different scans. We get diagnostic certainty with our imaging. We're able to look at what the tissue of the myocardium is actually made up of. Is there fat deposition? Is there iron? Is there edema? Is there fibrosis or ischemic scar? And we're able to track disease progression and regression, for example, in conditions such as amyloidosis and Fabry's disease. And we can avoid the need for invasive tests with cardiac MR. So we can avoid unnecessary invasive coronary angiography or endomyocardial biopsies if we're able to see what the tissue is composed of on our MR scans.
Dr. Asha, you have only 10 minutes.
Yeah, that's fine. Thank you. It's a one-stop shop for me. I'm a heart failure and imaging consultant. So for all my patients that have heart failure, I perform a cardiac MRI to look at the etiology of heart failure. And we can also give stress to look for underlying coronary disease. So case one, this is a 78-year-old male. He presented as an NSTEMI with an elevated troponin. His coronary angiogram demonstrated diffuse severe LAD disease. The question for the cardiac MRI was, is the LAD territory viable? And can we therefore refer him for a CABG because he does not have good targets for PCI? So this is his cardiac MRI scan. I hope the images are playing for you. You can see we have similar views to echocardiography, so 4-chamber, 3-chamber, 2-chamber, and we can see he's got dilated atria, he's got severely impaired left ventricular function, impaired RV function, and we can see there's thinning and akinesia, particularly of the anterior wall, anterolateral, anteroseptal, and anterolateral walls. So we already are worried that these segments are not going to be viable because of the way they're looking and not moving. And if we move on to gadolinium imaging, this is late gadolinium imaging to look for any scar. We image after 10 minutes of giving the contrast. We can see that there is significant, almost transmural scar in the entire LAD territory. So all across the anterior wall, the anteroseptum, the anterolateral segments, and this is well seen here. So the LAD territory is not viable and we cannot refer this patient for CABG. So unfortunately, he can only have medical management going forwards. And the cardiac MRI has been key here in making this decision. Case 2 is a 59-year-old lady, a smoker, who presented with an anterior STEMI. These are her angiographic pictures, just the beginning and the end. So as you can see at the beginning, her LAD is occluded. And by the end, they have attempted to stent a significant proportion, but still this is not the excellent angiographic result we hope for. This was a difficult and complex case. And we know even from this result that she is going to have impaired LV function and scar. And this is her echocardiogram. So we can see here she's developed a significant LV aneurysm at the apex. So this is significantly dilated and aneurysmal. You can see slow flow here, spontaneous echo contrast. And this is high risk area for development of LV thrombus. You can see the only contraction is coming from the bases of her ventricle. And that's why she had an LV with contrast echo before going home to make sure there was no thrombus at that point. And she was discharged on dual antiplatelets and some heart failure medication. So the question for her cardiac MR was to look for any development of LV thrombus. And is there a likelihood of recovery? She's a 59-year-old lady. She has no other contraindications to referral for heart transplant or LVAD. And this is an area that I have an interest in. And so it's important for me to refer my patients early if they aren't going to recover. So looking at her cardiac MR, looking at the moving cine images, similar to the echo, we can see here the thinning and akinesia of the LAD territory. We can see this aneurysmal apex and the contraction only being provided by the basal segments and some RV contraction as well. And we can just see this blood flow swirling around in here because of low cardiac outputs. And if we move on to our early gadolinium imaging, so this is where we take our imaging straight after giving contrast and we look for any LV thrombus, intracavity thrombus, which is hypointense and black, or we look for any blackness within the myocardium, which is microvascular obstruction. And you can see here, this lady has got a large thrombus just sitting here in her left ventricle. And we sort of anticipated that because she was at high risk given the cardiac findings following her MI. And if we look at the late gadolinium, this is PSAR imaging, we can see that this is all completely gone. This territory is non-viable. It's thinned, akinetic, transmural scar in addition to this thrombus. So for me as a cardiologist, it's really important. This MRI has helped me understand that she's now got thrombus and stopped her prasugrel, changed her to clopidogrel with warfarin, and referred her for advanced heart failure assessment because she's not going to recover. She's young and she needs to be assessed. Even if she doesn't need a transplant or an LVAD at this stage, she will require it in the future. The next case is a 62-year-old gentleman with angina who's had previous PCI. The question is, has he got any inducible ischemia that warrants us doing further another invasive cath? So looking at his heart function, these are the cine images. He's got good biventricular function, normal valvular function. This is adenosine stress perfusion. So adenosine can be given at 3 different increments. Patients mustn't have caffeine in the morning. They can't be on certain drugs like dipyridamol, and they can't have asthma, poorly controlled asthma. We then stress them and we do stress imaging here. And you can see that this appearance of this black is a perfusion defect in the inferior segment. So in the base and the mid, there is a perfusion defect in the RCA territory. And if we compare this to rest perfusion, there is no inducible perfusion defect here. So therefore, this is an inducible defect and likely the reason why this patient has angina. And there's no ischemic scar. So this is beautiful late gadolinium imaging demonstrated black myocardium with no scar, no evidence of previous myocardial infarction. And so because we found this inducible ischemia, it correlates with his symptoms. He was then referred for invasive angiography and plus or minus PCI. So just some final cases to go through. Sorry, let me go back. Just that come up on my list. These are a few cases in my lists in the last few weeks, just to show you how interesting cardiac MR is. And you just don't know what's coming through your list every day. And that's what makes it really interesting for me as a clinician. So this is going quite quickly. This is our HASTE imaging that we look and we check all the connections and we check the extracardiac anatomy. We check the lung fields. You can see here, this lady had an MR for ectopics to see if there's any structural heart disease. And her heart is completely displaced into the left side of her chest. So this is an abnormal position for the heart. And if we look at the cine images, again, you can see this looks very abnormal to your normal scan when you're reporting, looking at images. Her entire heart is shifted over to the left side. And this is an incidental finding of a patient that doesn't have a pericardium. So she's got pericardial agenesis. Other indications for doing scans, especially with my field of heart failure and cardiomyopathy, I do a lot of scans for hypertrophic cardiomyopathy. So this is a lady that's got sigmoid septal hypertrophy. A differential for this could be amyloid, given that she's got some pericardial effusion, she's got dilated atria. So that's how our cardiac MR will help to find out if this is the case. It doesn't typically look like amyloid, but it's something to think about. But her nulling was normal, but she did have this clear non-ischemic distribution of bright mid-wall gadolinium enhancement in the areas of hypertrophy. And this was in keeping with hypertrophic cardiomyopathy. And finally, another patient that landed on my table to assess the cause of her effusion, and she was breathless and had difficulty tolerating the scan. And here you can see the heart just swinging around in the pericardial fluid. You can see some RA invagination. You can see this large global pericardial effusion. And this lady then had to be admitted after her outpatient MR to have a drain for this fluid. Here are some resources to help you in cardiac MR training. So these booklets are very useful. You can download them on your phone and have them to hand when you're scanning patients. It has all the different protocols you can do. It has lots of examples of imaging, and there's one for congenital heart disease as well. There's this textbook that I'd recommend as well, and I'd recommend you becoming a member of BSCMR because we have webinars online there talking about planning images, talking about stress perfusion, and talking about the latest updates in cardiac MR, and everyone can be a member from any country. So thank you very much for listening. These are my acknowledgements, and
thank you very much.
One of my favorite places in Pakistan. So thank you.
Bye-bye.
Sir, this will be the end of the session. This will be our last speaker, since one of our speaker, Mohammad Ishaq, due to certain commitments, he was not available. Thank you, madam. Thank you, sir.
बस खत्म हो गया ना?
Yes, sir. This session is over of cardiac imaging. Hypertension.
Assalamu alaikum, ladies and gentlemen. And this is the start of the last session, which was not the last, but so the session is all about hypertension. Quickly starting the session, I would like to invite all the panel of experts on this stage. I would like to invite Professor Mahmoodul Hassan on stage if he is around. Professor Tariq Abbas, Professor Abdul Rashid, Professor Feroz Mehman, Major General Nadeem Fazil, Professor Amir Bandesha, and Professor Khalda Sumro. Ladies and gentlemen, we are moving towards the first talk. That is the hypertension in elderly. This would be delivered by Professor Harun Baba. Please welcome him.
Assalamu alaikum. Assalamu alaikum. It's my pleasure to be here at the end of the session, I think. I have some reservations before I start my talk. Brigadier Nadir is sitting here. Hypertension is the most common disease and the most lethal disease. And the session has been put at the end of the day. You can count how many people are sitting here. So I think you should write down this complaint. I am thankful. I first said this word. But what I'm saying is, because if a common disease is not discussed, what is the benefit? What benefit we are giving to the people who came here to listen? Because most of them have left. Anyway, let me start it. हाँ तो सेशन में उसी जिस तरह था करना चाहिए था. Anyway, मैं इसलिए कह रहा हूँ कि आखिर में आप ऐसा सेशन रखते हैं तो फिर लोगों का जो इंटरेस्ट है वो वेन हो जाता है. तो इसको नेक्स्ट टाइम अगर रखें भी सही तो कहीं बीच में रखें ताकि लोग सुने इसको, उसके ऊपर डिस्कस करें, क्योंकि वन ऑफ द मोस्ट कॉमन प्रॉब्लम. वो कहाँ है यार? यही है. कहाँ से आगे पीछे होता है? हाइपरटेंशन के बारे में most of you, all of you know what it is. Most prevalent disease in the world. एक आदमी जिसकी उम्र 50 साल है, उसका 90% चांस है कि when he is in his 60s or 70s, he will develop hypertension. 65% of the people who are above 60 or around 60 have hypertension. तो ये तो उसकी प्रेवलेंस है. कोई और डिजीज अगर ऐसा है तो मुझे कोई बता दे. And it is one of the most lethal diseases which we come across